Hello and welcome to this edition of Dr. Clark Reports. I'm your host, Dr. Gary Clark, and my guest is my friend, Dr. Ashley Doucette, who is a psychiatrist here in the city of New Orleans. And greetings and welcome, my friend.
Thank you so much, Dr. Clark, for having me here.
Yes, you know, and I've known you for oh so many years, and you're a good friend. But tell us about the nature of your practice and how it works.
Currently,
Yes.
I am a local psychiatrist here in New Orleans, Louisiana. I am working via telepsychiatry at this time, which is a new branch of medicine that's up and coming. It's actually called telemedicine, where because there's such a higher need and there's not enough physicians out there to provide, it's actually like Skyping or online messaging. It's encrypted and it's confidential and compliant with all HIPAA standards. And I'm able to see patients in Opelousas, Louisiana, when we leave here today without having to drive 3.5 hours.
But it's amazing. You can go from here to St. Landry Parish and not have to use any dollars in terms of mileage.
Yes, I can even be
Yes.
in a different state and see patients here in Louisiana. So I could be on vacation, and if my patients need me, I can log on, access them, we can talk, I can send medication directly to the pharmacy. It's very efficient, it's very good. Of course, there's always pros and cons, but overall, I've been very satisfied with the program that I'm working with, and I know it's allowing us to provide care to people who otherwise would not receive it.
Well, would it allow you to see more patients than ordinarily that one would?
Absolutely.
Or does that change?
No, absolutely, because
Okay.
again, you're cutting down travel time. Certain clinics, but not all, but thank goodness the one I'm working with has an EMR or an electronic medical record. I'm not flipping through the chart looking for paperwork, trying to find something while I'm talking to a patient. I can look at them on one half of the screen. On the other screen, I'm typing up my notes. I can pull their file. I can pull their medication. I can pull their allergies. It definitely makes seeing patients more efficient in the time that I'm seeing them. We can spend more time discussing what's really going on with them and not paperwork.
Well, I don't know if this is important or not, but what about the nuances that a patient would have? Is that important in terms of looking at their carriage, their view,
Yes.
and their presentation?
Yes, and that's
Yes.
one of the cons to it that we're working on, I would say, within the industry. It is hard over a computer to see what's known as a patient's affect or their mood, how they're feeling, if they're agitated or anxious or nervous and jittery. But you can also angle the camera back, and so you're able to see them at a higher definition. So with time, I definitely think things are going to get better. And again, just to be able to see patients in some way, shape, or form is a little bit better than not seeing them at all.
Absolutely, and there's something too that you had mentioned to me earlier. This whole thing of continuity of care.
Yes.
Highly important, and yes.
Very important and a major problem right now, and unfortunate. Again, it's because the need is so great. Often patients are being seen by multiple physicians at one time. So for example, you can go to a community clinic today and see Dr. A, and perhaps in your follow-up appointment, Dr. A may not be available or working that day or working another clinic. You may see Dr. B. Dr. B may not think the same way that Dr. A thinks or was trained differently, so they may change the medication. The next time you come, maybe you'll see Dr. A or B or C again. Again, does the medication change? Do you have to retell your story? And as a psychiatrist, the things that my patients want to discuss with me are difficult. And often to retell those painful things, it's hard. So they just stop seeking treatment.
And so I see, and when they stop seeking treatment, then they're out in
They're
in the
just out
community,
there,
yes.
and symptoms exacerbate, whether that's depression that leads to suicidality, whether that's bipolar, psychosis, schizophrenia that leads to, again, hurting themselves, hurting other people. It gets very dangerous. It becomes costly when their symptoms exacerbate. They go back through the emergency room. Those are all things that if it could be treated on an outpatient basis and maintained, you wouldn't have to see repeat what we call frequent flyers within the emergency room in psychiatric hospitals.
Well, now at the core of your practice, what do you normally see?
I really see a
Is that-
variety of
okay.
everything. A lot of times people say, I didn't know you did that as a psychiatrist. I'm like, yeah, I do all of that. So your general mood, mood disorders, so depression, anxiety, what we would call bipolar disorder, schizophrenia, that's along the psychosis spectrum. I see patients with dementia and delirium, some of your elderly patients. I see patients with substance abuse problems. I'm a Suboxone provider for patients with opiate dependence, whether that be heroin, whether that be pain pills.
Yes.
It's like the new methadone. That's what Suboxone is. I also I do therapy. I do counseling, whether that's CBT, cognitive behavioral therapy, or Christian-based spiritual therapy. I target my treatment toward my patient. Everything is geared toward what's going to be unique and best for them.
Well, you know, when we look at psychiatry in that field and that you're in, there are certain cultural biases that have always presented themselves. And sometimes, and even you may find that African Americans and people of color have been reluctant to see psychiatric help when needed. And you find that even also for individuals who are in certain disciplines who come out of the military, or a certain environment such as the military, certain environments such as policing, are reluctant to see these sorts of that sort of care. What do you say to that? Yes.
The shrinks were not scary. We really aren't. Its stigma is twofold. It's within the community. Patients are afraid to seek help, period, for their depression, whether they feel like, oh, I'm a weak person, especially men. I'm not going to say I'm depressed. That's going to make me seem like I'm
all right,
weak.
that's a gender issue as well, yes.
Yeah, it is a chemical imbalance, and we have specific criteria. It's not just being sad or having some blue days. We have specific criteria that we look for that you have to meet. So that's one thing. Patients aren't seeking treatment. It's a bias within the medical community. I can remember when I was in medical school, I had some close friends and family say, well, why would you be a psychiatrist? You didn't even have to go to medical school for that. Or a lot of people don't think I'm a real doctor.
But you do have to go to medical school to be a psychiatrist.
Yes, you do. And there's psychology,
yes,
which does primarily therapy. And then as a psychiatrist, you have the component to prescribe medication as well. But each are equally important. And like I tell all my friends in medical school when we were there, I said, wait till your patient comes out of surgery and you didn't know they were drinking alcohol every day and they're delirious and they're hallucinating. Then you'll call me and you'll see how important my job is. So I think it's twofold. We have to educate the community, and then we have to also educate the medical community the importance of mental illness.
I see why that becomes, that's very important. But, you know, I always used to tell friends, you know, that I would think that, you know, in the African American community, they've been reluctant to go and see psychologists or even psychiatrists, or want to, for those who may want to do it, because it's costly.
Absolutely.
And so what I say is that what African Americans and other people of color have done over the years, they just call up their friends and use them as what therapeutic purposes.
Yes, absolutely.
Yes.
Their family, their friends, their pastors for support, and that's still important. That's still needed. But you're right. It is financially costly, and that's one thing I'm very excited about with the Affordable Care Act, is that mental illness is now placed on the same level of physical illness in terms of treatment. So you can seek treatment and it should be covered under your health insurance. I hope that encourages people to seek help. People are hurting, and sometimes you just need a little bit of help. Just need a little bit of help.
Tell me this: at what point does one need psychiatric care, psychiatric help? I would look at the individual sometimes and I would say, well, you know, that person's clinical. But then again, I'm a layman.
Diagnosing people.
But tell me the story. But at what point does one say, all right, this individual needs help, or I need help? When must one go?
One, to answer your question in a more immediate, emergent base.
Okay.
So psychiatric help, like a psychiatric inpatient hospital, an emergency room. That would be if you're a danger to yourself, you're having bad thoughts, wanting to hurt yourself, significantly depressed, thoughts like you want to hurt somebody else. You know you're perceiving things that aren't there, or that other people tell you aren't there. Things like that, those are more emergent situations. On an outpatient basis, poor sleep, poor appetite, mood irregularity, generally not feeling like yourself. Sometimes you just need to talk it out. It's not always medicine that's the answer. Sometimes just truly speaking it out and putting it on the table to someone who's completely unbiased, who doesn't know you, who cannot judge you, and getting it out there, it really, I mean, clinically, we've seen it in studies, it's effective, and they've shown it that medication alone, therapy alone compared, they're equally and relative in treating patients. The combination of the two is the best.
Now, I know that you have various forms of mental illness and various degrees of mental illness, but can mental illness be cured? I know this is a tough, maybe a tough question, but can certain illnesses be cured?
Cured? That might be hard to say in terms of cure.
Okay.
Put it like this. Mental illness is a chemical imbalance, mood disorders, whether it's depression or psychosis when you're seeing things that's not there, in terms of neurotransmitters or chemicals in the brain. So if I would put a little electrode on your brain and put in the right spot and target the right neuron for the right neurotransmitter, I could make you see and hear things that aren't there.
That does not exist.
That does not exist. Now, this isn't ethical anymore. We don't do this to patients, but when I was in my training, we've seen videos from the past where a woman was just as cool, calm, and collective. They ramped it up to a certain voltage, and she was elated, and she's up, and she's seeing and hearing things, and they brought it down to a certain voltage, and she's crying and depressed, and almost like turning a television dial. All that to say, yes, can you get the chemical imbalance back and restored? Often, yes. Do you have to take medication for the rest of your life? Sometimes. Do you have to take medication always for the rest of your life? Not always. So is that an answer to a cure? Maybe. That you do not have to always take medicine the rest of your life with proper diet and exercise and a support. I think a cure is stretching it, but can you live a healthy, well-balanced, full life? Yes, absolutely.
Well, we live in an environment right now that which is why I wanted you to be at this table and to join me, because in this post, and we're still saying this, in this post-Katrina environment, that we're finding that there is indeed a certain amount of mental illness which we see, not only as a result of Katrina, that we see it being manifested in our community, but also with veterans coming back from the military who have been involved in the war, and they've had to go and make various entrees in the conflict. We see an escalation in some form of mental illness, and I know that we need to find this addressed. Do you see this in your practice and also in the field?
Absolutely. That was why I decided to stay here. I was a first-year student in medical school when Katrina hit. I didn't even think of doing psychiatry when I first started medical school. I wanted to do pediatrics or OBGYN. I had a wonderful mentor, Dr. Jan Johnson from Tulane University. She inspired me, and I saw her passion and her commitment. And after the storm, once we did come back, seeing how it affected people, when I did decide to go into psychiatry, I said, well, why go anyplace else? Why not stay home and train? I mean, this is the best place to learn. I have met so many patients, and it's emotional. I've met so many people that have not had no prior symptoms of mental illness until after Katrina. PTSD is very real. It can present itself in a variety of ways. I've worked through the VA, through my training. That was actually the first place I was introduced to telepsychiatry, was through the VA. Our vets, they're in desperate need of help. I think it's good to have a therapist for everyone, for everyday life. So if you can imagine coming back from the things that they endure, they all need someone as a support system, someone that they can talk to. And again, the need is so great.
The homeless veterans?
Yeah,
yes.
I worked with that as well. Again, with Jan Johnson and the homeless program with the VA, we went out into the community, under the bridges, in the interstate, into the French Quarter, seeking veterans to bring them in, to get them linked back up with the VA system, to get them treatment.
Well, how were you received when you approached them?
Well, I'll be honest. We put our jeans on, and I pull my hair back, and most people don't. They say anytime I don't look like a doctor, like, oh, you look like a kid. Sometimes it's a little frightening, but generally, well received. If you show a kind heart and a kind smile, people, I've realized, that generally can see that and are receptive of it.
It makes a big difference. Yeah, and when they see that you care, and then they become receptive to your message, and are they receptive to your treatment?
Now that's always the question. Sometimes I will say, are they compliant with the medication all the time? Not always. Are they compliant with my treatment plan? Generally. And a treatment plan is more than just medication. And I'm aware of that. But I work with my patients. It is their treatment. And I think open communication and a good doctor-patient relationship, that does improve compliance and promoting them to adhere to the treatment plan that you all created.
Oh, yes. And again, I would like to remind my viewing audience that I'm Gary Clark, and I'm speaking with my friend, Dr. Ashley Doucette, who is a physician here in the community, a psychiatrist here in the community. And Ashley, I've known you for oh so many years. I remember when you were in school at Tulane, and you were preparing for this particular journey that you're on. But will you please tell my viewing audience the Dr. Ashley Doucette story?
Well, I was born and raised here in New Orleans. I went to Ursuline, then to Xavier, then to Tulane for medical school. As I told you, I was a freshman when Katrina hit. We moved to Houston. That was a very trying time. Moved back and decided to stay here for residency. I have wonderful parents who
yes.
Very, very supportive. I've had wonderful mentors. My grandmother, who unfortunately passed away, she was a teacher. She gave me the foundation that I needed to work hard. I'm a hard worker, but I'm just very blessed with the people in my life. I think we all go through our struggles, and I'm no different than anyone else, but I do think that this is my purpose. This is not a career that is for everyone, and I'm very much aware of that. You've got to be able to check your own stuff at the door, because when you're coming in and you're depressed, I've got to give my full attention to you, and you have to know that. And what I tell myself, what if I'm the last person? What if I'm the last line of defense? If you are just suicidal, you can't take it anymore, you don't think anyone cares, and you go into that hospital, you go into that emergency room, and you just want to give up. And I walk through that door. What's going to happen next? Am I going to listen to you? Am I going to sincerely listen and make you feel validated and important? Whatever's going, whether you're going to take my medicine or not, to where you aren't going to take your own life or proceed to that next step? Or do I just walk in, see you, write a note, and leave? And that's what I try to do to keep things in perspective for myself.
Who are your personal and professional influences along the way? I know you talked about individuals at Tulane. Tell me about your personal and professional influences. Truthfully, at the top of the list, my parents. I cannot ask for better parents. They are intelligent. My mother is the most organized woman I've ever met in my life. I've had such a great foundation that I attribute it to them. Again, I told you my grandmother. Professionally, Jan Johnson, Dr. Arnold James, psychologist. He's phenomenal. Again, his his doctor-patient relationship, I really, really admire and respect that. And to me, she's St. Julian, an old family friend, yourself, people who have mentored me throughout the years. And I'm probably drawing a blank in some really important people right now. Yeah, exactly, because you've done so much in your life. I remember when you were also with the honeybees.
Yeah,
the first set of honeybees. Yes,
I was. That was a lot of fun. That was definitely.
And you were in school at Tulane at the same time.
I was at Xavier then, and that's someone else. Yes. Corvallis Webster, Dr. J.W. Carmichael. Again, I would not have gotten into medical school without their guidance and their support. It's so many people. It's just not me. And that's what I tell my patients, most importantly. I'm just a tool in God's toolbox. I don't heal you. He blesses me with the knowledge that hopefully will help you, but he does all the healing. I'm just here as like a little interface. And I do believe that. I believe that.
Well, you're also about to go into a new realm with the coroner's office, a new area in your endeavor. Tell us about that.
I just joined the team with the upcoming coroner, newly elected coroner, Dr. Jeffrey Rouse. Again, another mentor of mine at Tulane. He's phenomenal. Came back from Katrina and was working without pay. Just really believed in advocating for mental health rights and for treatment of patients. And so he offered me the ability to come on the team.
That's
and come back working with
outstanding.
him, and I'm very excited. So as the coroner, as a psychiatric coroner, because I was like, a coroner? I thought that was autopsy. So that is one version of the coroner's office, but you do have a psychiatric division of the coroner's office who does something called a coroner's emergency commitment, or a CEC, as well as an OPC, an order of protective custody. So all that's just saying, if someone in your home becomes a danger, and you need the police to come out and not take them to jail, but they need psychiatric help. How do you get the police to come and do that? Well, you would call the coroner's office, and you would tell them what's going on, and they would write you, listening to your story, okay, this person is a danger to you, they're a danger to themselves, they're threatening to hurt themselves, yourself in the house, burn the house down, whatever the case may be. We then give you the OPC, the order of protective custody. You bring that to the police, and from there, that individual is picked up and brought to the emergency
Now,
room.
who would know to call the coroner's office? Because that's good to know that you would call them first for this sort of assistance or help.
Usually
Yes.
you're routed towards
That's what I would
that.
imagine. Yes.
But I will say I briefly had the chance to meet with Dr. Rouse on this week. But I know he's got some wonderful ideas and plans for the coroner's office. And I know educating and getting out into the community and letting them know what we do in the coroner's office is something important.
Well, I always say that, you talk about some of the forms of mental illness, I always say that, hey, this whole system of capitalism and the system that we have, that we live in, that we so love and adore, but it's a dog-eat-dog world.
It is. People are stressed out.
One has to be powerfully prepared to exist in this world. It's not for the meek and the mild.
And psychiatric care treatment, it's not consider it like a tune-up. How you go for any other physical. You go to the doctor, you get your blood pressure checked, and if your blood pressure is off, they give you a little bit of medicine. Sometimes you got to take it all the time. If you keep eating bad food, then you don't exercise. But if you exercise and you diet and you do what you have to do, you get off the medicine. Sometimes psychiatric illness and treatment can be like that. What if you're just not sleeping well? You have to sleep. Your body has to recharge. What about just coming in and getting some treatment for that? What about talking about the anxiety? Again, medicine is not always the answer. Sometimes we can talk it out. 2 or 3 sessions and you're done.
Well, let me say this. Years ago, I chaired a Louisiana State Police Commission, and I always thought that the most important test that any officer could go through was a psychiatric examination, and that's the pre-test. And because to many they overlooked that, because we have to give individuals tests and wonder, why do you want to carry that gun? Why do you want to put yourself in harm's way? And that test is very important. Do you think those sorts of tests?
I do think those
Yes.
tests are important. I think and I hope that in the years to come they will evolve and
Okay.
start looking at those things, like you said. Why do you want to carry a gun? Because on a general psychiatric examination or a mental status exam, that question wouldn't necessarily be answered.
Precisely.
So I think we need to look at, what are these assessment tools that we're using? Are they measuring the things that we want them to measure? We can create a test, but we have to make sure it's truly measuring what we say that it's going to measure. I think, and I hope that's something that will change. Something needs to be done better than the system that we have now. And the regular exam that we have, it's necessary. We need to do better.
Now, I know on a local level, there's been part of the criticism has been that not enough efforts have been given in terms of public assistance for psychiatric and psychological assistance. And it's been you hear that all the time, that when if you go to the hospital, when you go to the emergency, that the money's been cut, the floor's gone, that the assistance is not there, and because of that, the residue of it is manifested in our community. We see it in the streets. We see it with the anger that's taking place in the community. We see it as a direct result of public dollars not being expended in the right way, in that way, yes.
Absolutely. I mean, and this is something that I think everyone needs to stop and look at. So look at these hospitals that are up and coming. Again, they're not, they don't have psychiatric beds, they don't have psychiatric wards, but eventually they see where it was necessary when the ERs are overflooded, when you have patients who are having chest pain waiting on a gurney for 30 minutes because you have no rooms. And if a patient is under a psychiatric commitment, they cannot leave the hospital. They have to stay there. They cannot be roomed with someone else. They have to stay there. So it's not like you can kind of put multiple people in the room. You're stuck. You're stuck with ICU beds. This is something that it's not going to go away. It's only going to get worse if it's not addressed. And we just lost the battle for the Medicare and Medicaid expansion in Baton Rouge on last week. I worry what our underserved, and I can't even say low income anymore. It's so beyond low.
Precisely.
What are they going to do? Again, because like you said, psychiatric care, it's expensive.
Right, and it bleeds into the middle class and community. It's all over.
All over.
Now, before we exit, I know you are you're highly involved in the civic community, and talk to me and to us about your civic engagement and your civic activities. Why you think is so important in the remaining 4 minutes or so that we have? Yes.
I think that I truly love my home. I love New Orleans. I see so much potential here, but we're a city that's hurting and we need to heal. I'm a member of Alpha Kappa Alpha Sorority Incorporated. They allow me to branch out and do so many wonderful things. My family, they keep me abreast to everything. My dad is great in letting me know what's going on in the community. I was telling you about some wonderful community organizations such as NAMI, the National Association of Mental Illness. National Alliance of Mental Illness, supporting family members of those suffering from mental illness. And that's something else which we didn't even get a chance to talk about, but those family members, they need help and support and education as well, and how to live with and support their loved ones.
Yeah, and as I see that, what do you see as the primary dilemma in our community before we exit?
Miseducation or lack thereof, just none, just complete none.
The lack thereof.
Lack thereof, where to get treatment, where to get access, what's going on with me. A lot of people, they don't even know that that's something that could be treated or could be discussed or could be helped.
And that it isn't, right, they don't even know that it is an illness that one may have.
They need to just discuss it with your doctor. That's the most important thing. Keeping an open, finding a doctor, whether it's a psychiatrist, primary care physician, that you trust, that you can tell what's going on.
Now, what is your aspiration for the mental for the mental community and for the community that we have in terms of the mental aspiration? I can't even get that out.
I get where you're going.
Yes.
Equality in treatment, equality in terms of funding and rights, that they are not taken advantage of, that they are treated fairly and equally and with respect by everyone, medical community, their families, everybody.
Okay, I want to thank you for joining me.
Thank you, Dr. Clark.
Outstanding, yes. And again, I want to thank my friend, Dr. Ashley Doucette, for joining me. As always, it's been a pleasure.